iPhone to project, so it takes little time. Ready, Jyoti? Yes.
Yeah, ready, sir. So, respected Chairperson Dr. Das sir, the organizers of the APDF, and I thank all of you for the kind invitation. The issue surrounding incretin is a burning controversy at present, and we do have sufficient evidence to support the safety for continued usage. There are two therapies based on incretins. One is the glucagon-like peptide analogs, injectable therapies, and they have demonstrated efficacy in bringing down the blood glucose and an added benefit on bringing down the weight and other cardiovascular risk parameters without the risk of hypoglycemia. And the oral agents, the DPP-4 inhibitors, have a similar role in glycemic lowering with weight neutrality and maintaining a normal blood sugar without the risk of hypoglycemia. And the major area of concern is to identify whether this animal is a wild animal or a domestic animal. And these are the merits and demerits of incretin-based therapies. And the present controversy is mainly with regard to the occurrence of pancreatitis and pancreatic cancers and thyroid malignancies. And these are the timelines in 2013. And the two erupted like a volcano, the one by Dr. Singh in JAMA and the other by Dr. Butler in diabetes care. And the subsequent scientific publications from the associations. And this is very similar to the Weber phenomenon. The Weber's phenomenon, where you look for something, you have pancreatitis with almost all the drugs. And going back to the Singh and the group which published in JAMA, it was basically a publication out of administrative insurance claim database. And they were looking at association between incretin-based therapies and hospital admissions due to acute pancreatitis. And there were some major limitations most of you are aware of in connection with the publication by Singh et al. On the administrative database selection of subjects, which cannot be regarded as a randomized control trial, not strong enough data, confounding factors not matched, and the diagnosis algorithm of acute pancreatitis. You go by 2 out of 3 criteria: classical abdominal pain, elevated enzymes, and evidence from imaging, which is not adhered to, and the treatment bias, etc., etc. And if you look at the incidence of pancreatitis, it is 1.5 to 3-fold higher in type 2 diabetes patients and across all age groups and more in men. And this is a data which is robust enough to support the safety of incretin-based therapies by Garg and his group in diabetes care. If you look across the 3 groups, exenatide versus sitagliptin versus diabetes patients on other therapies, the incidence of acute pancreatitis remains almost the same. So this anyway is not linked to therapies based on incretin. And again, the evidence on exenatide, sita, and diabetes controls. And the ADA's response to Singh et al. On the safety of use of incretins and not to change the present practice of using incretins in our practice, and the FDA safety communication. And we are widely prescribing incretin-based therapies globally, and that is because of its profound benefits addressing the pathophysiological defects in type 2 diabetes. And none of the serious effects are susceptible to be directly related to the drug. And we do have publications related to liraglutide. This is one of our publications in type 2 diabetes in a real life setting, especially type 2 newly diagnosed drug-naive subjects. And we were able to demonstrate a reduction in fasting and postprandial glucose values, reduction in A1C. There is a profound statistically significant reduction in the A1C values, and weight reduction is up to the tune of 8.5 kilograms and improvement in the glycemic and non-glycemic parameters, and even we hypothesized the possibility of liraglutide resulting in a probable remission of type 2 diabetes. And then came the Peter Butler article, and in red you can see the incretin group and the O is the other group. They reported from a autopsy sample that there is a 6 times higher increase in the beta cell mass and the alpha cell mass, and then increase in the pancreatic mass in the incretin therapy group. And they even had pictures of microadenomas and neuroendocrine tumors published in Diabetes Care. And looking into the depths of this publication on the arguments that these groups of drugs can produce pancreatitis, there was a bias involved in terms of age of the individuals, in terms of diabetes duration, and obviously pancreatitis is more with type 2 diabetes, irrespective of the therapy groups. And the O group was 18 years younger, and some of those in the therapy were type 1 and not actually type 2 diabetes patients. And a good percentage of patients on incretin therapies develop microadenomas. In real life, microadenomas are extremely rare. And the GLP has also increased after gastric bypass surgery, and we do have follow-up after 8 years of bypass surgeries, and they don't develop microadenomas or pancreatic cancers. So this again is questioned, and the scientific associations have come out with safety data, and we do have publications to negate the argument that there is a exocrine ductal pancreas proliferation leading on to pancreatitis and ductal metaplasia and neoplasia. And recently there was a NADDK NCI workshop, and there again Peter Butler presented his data on rat studies and postmortem studies in favor of increased risk of pancreatitis and pancreatic cancer in those subjects on incretin-based therapies. And the counter argument were on human safety data and no expression of GLP-1 receptors in the exocrine pancreas, and thereby reassuring that there is no causal relationship at all. And the US FDA mentioned it, data available till now is inadequate for any conclusion to be drawn and will require adequately powered long-term epidemiological studies. And we have releases from the European Medical Agency, from the US FDA, all reassuring the continued use of incretin-based therapies, both injectables and oral drugs. And what about the cardiovascular safety? We have ongoing clinical trials, the TICOS, the EXAMINE, the SAVERTIMI, Carolina, and recently, last week, an interim report from SAVERTIMI was published in NEJM, again reassuring the safety of the drug, and it is absolutely cardiovascular safe. And so also is the publication in the same journal on allogliptin, that is the EXAMINE trial. And recently, on diabetes and cancer, AAC and AC has come up with a consensus statement, and again, gliptins and the GLP-1 agonists have no connection and no evidence of pancreatic cancer in humans. And we have, as per the ADA position statement and the consensus statement, more than 80,000 subjects on several clinical trials across the globe, looking at almost all the serious adverse events, and we don't have any concern at present. Mobile phones will not produce cancer, but let us be cautious. And at present, we can be sure about the safety of incretins and all these therapies, and we can continue with the current prescription.